with closely as local charities advocates for people with adults with learning difficulties and disabilities, and just the things, some of the lessons that we learn out of that, the challenge that we found during COVID exposed things that probably were perhaps more hidden and then got exacerbated as a part of that. The social worker that was talked about there was actually a locum working for us. She's no longer working for Dorset anymore. She got burnt out. She was very connected into her caseload, and that was to the detriment of her own health. But fortunately, is still working within social care, but on Dorset, which I think is helpful. And I think it just goes to show that kind of lack of suitable placements. Somewhere to look after, not just to care. It's really challenging. How do we do that? We're doing some work with Volunteer University, some research around social care recruitment and retention. It's not like any other. It isn't just a job. You don't just turn up 9 to 5. It really is important that we recruit the right people into that space who can care for people like Ruben. I'm pleased to say some good outcomes around that in terms of his current placement. He's in an assisted living flat on his own and doing well and thriving, which is really helpful. And reducing isolation was a real challenge during COVID and remains, I think, a real challenge. We heard just this week, I think the American central banker talking about isolation being one of the biggest diseases that will hit globally will hit us. People feeling that sense, and you heard that desperation through that. So, we recognise there are things that we could have done differently. Looking back, hindsight is always a wonderful gift, isn't it? That you can look back and say, could we have done things differently? But it's I think the good thing is that he has had a positive outcome in that sense. But it's a terrible journey that he's had to go on through that place.
Do you want to say anything more, Debbie, before we go out?
Yeah, no, I think that was really helpful, Matthew. And I think the only other area for me that was really pertinent and is much wider than our social care colleagues and learning for us all was around that exclusion of the family.
Yeah.
and around that, it doesn't matter where we place people or where people are living. It's around having that robust care plan with actually sort of the family's information and how they want to be involved and not excluding them. And I think that came across really sort of loud and clear and is sort of good learning for us all in everything we do, really.
Thank you. And as you said, Matt, the mission's achieved through that video, isn't it? So it's the second time I've seen it, and it doesn't lose its power, actually. So Dawn, I know you've got your hand up.
Thank you, Jenny. A really powerful video, and I've watched that a number of times now, and it doesn't fail to be powerful. Just building on Matt's point there around social care recruitment and retention and the research. My reflection is about all the research that tells us about the links between positive staff experience and people's ability to care. We play a role in creating environments for our people to flourish so that they have the capacity to be able to give to the people within their care. And that's something that particularly strikes me as we think about this story.
First question. So, what's the difference in the approach at Fox Court?
So my understanding is Fox Court is the assisted living, so he's in his own flat. So he's got some support and people first wrapped around him. Support there, very different. He's not obviously we've not so strict. We've not got this. Yes, he's not lonely. He's got a around, which is really helpful. Yeah. And organisations like People First are really integral and key to that, as well as his family. Obviously, they've got a distant relationship in terms of being in Spain, and I don't know how that's working out currently now, but I think that's one of the key differences for him.
Yeah, I think so. If you substitute looking after for loneliness, I think what's becoming apparent in research and just generally is that caring bit is actually about the community, which is in the vision, and just making sure that people feel connected. And there's now plenty of research suggesting that loneliness has a massive effect on health, and it kind of needs to be part of our preventive strategy going forward. And understanding that it's not just about caring for what we see, it's caring for the softer stuff. And if you care for the softer stuff, we'll get a lot more out of whatever we put in. So it's very powerful and very interesting.
Yeah, it was really just an extension of that point. It was just, the learning point, so that this is the impact of isolation on well-being, isn't it, really? So a very specific example here, but if we look at the demographic of the population of Dorset, we've got lots and lots and lots of isolated people for all sorts of reasons, be it a physical or mental health need, be it just an age thing, because very often older people are living on their own. And if you look at the example that's given about antidepressants, and I've no idea of the detail, but as a clinician, you would quite like to wrap things around that person, but you're not quite sure where to find that wrap around. So therefore, you're sometimes left with a medical decision, a decision to make. And I think part of our strategy is about that, and I do wonder about that, where if we could better utilise the voluntary sector in that regard of trying to offer assistance, because quite frankly, people just often benefit from just having someone to sit and talk to on a fairly regular basis. They just feel people like to talk as a whole, don't they? And if you give them that opportunity, then they do feel better about things.
John, then Lisa, then Siobhan.
Yeah, good morning, everybody. Thank you for bringing that story. I hadn't seen it before, and it is profound, isn't it, to hear that narrative. I guess there were a few things that I really noted. I think the first of them, I've called it navigation, and there was that phrase that said the fight to get into Portland Place, and I think what it reminded me was the points of care and intervention were complicated, and a sense that it didn't work out, that the stay at Portland Place, but it was a fight to get there. How do we equip people to have pathways and to be able to support them through not just what is the right place, but to do that in a way that they can navigate through it? It felt so challenging for them when I was hearing about that. So how people navigate and how we put people first, using those words to be able to get the services and the wrapper that they need. That was the first thing that struck me. I was then somebody else mentioned it a moment ago, the difference between looking after and caring for. And I was really thoughtful about, what we should be expecting, shouldn't we, to care for all of the people of Dorset for the services that they need. But I'm conscious about, are we set up, are we creating services that meet that standard or not? How do we handle that and think about what is the standard that we want to offer for everybody in Dorset? So that was the second thing that really came through. And then I was really thoughtful about all of our teams who work in the Dorset ecosystem and their role supporting Rubes and his brother, because I was thoughtful about the prescribing point around antidepressants. I was thinking about the colleague who was so burnt out, having worked in this environment, that there is something about how we also think about and support every individual who's working in this context as well, because I got a real sense that they were working so hard to be able to provide care and support to Rubes and his brother, but we didn't make it. It didn't get to where it was. So some really profound reflections from me on that. Debbie, thank you for bringing it, and I'll follow this from this stage. But thank you.
Thank you. Before I really come back in, I'll just pick up the other questions. So I've got Lisa, then Siobhan, then Patricia.
When Dawn did her people presentation, one of the things you said was people run through everything we do. And I think as a board, and I think if we listen to that, we'll do this. We've got to be really conscious that sometimes our targets and our KPIs can dehumanise the need and can dehumanise the solution. So I think it's really important to kind of have that seared on our brain that people run through everything. And when we start setting our targets, make sure that there are some human targets in there as well, because this is about human beings, whether it's the social worker who gets burnt out, whether it's the person who has a need out in the community that we're trying to fulfill. So I guess it's just a comment. Let's remember that in every aspect of what we do, we're actually talking about human beings. So let's not medicalize. Let's not get too clinical in a non-medical sense. And let's remember that sentence, people run through everything that we do, and our targets and KPIs should reflect that.
Thank you. Very powerful. Siobhan?
Yes, the first time I've heard, and it does make you feel very emotional. My reflection, I mean, Patricia and I actually have met a family who a really, really difficult and sad case where I met them not that long ago, probably about a month ago now, and actually the relative had a learning disability and unfortunately died over a period of time with lots of touch points in our system and definitely within the hospital. And actually the themes in terms of isolation and not listening to the family have just, it's just really resonated with what we've heard in that film, and the fact that actually we do dehumanize, and how do we develop a real personalized approach to care in whatever setting that is. And obviously within the acute setting, we're rolling out McGowan training. We're really learning from incidents and continually learning, and are learning from this particular instance. But what was fascinating was this family were just so amazing and actually have really offered to help us make things better. And I just think there's a real opportunity in how we engage people, not at this sort of endpoint, but further upstream, in really being part of helping us be better.
Patricia, do you want to come in now? Or
I'll come in now. So I this is not the first time I've seen this film. I actually saw it on TV, which is why I was really adamant that I wanted it to come to the ICB. My head is in a broader space like Siobhan, which is how do we make sure that we provide the right services that care for people in the way that they need and want to be cared for. And when I think about the fact that we still spend a lot of money on social care for adults with learning disabilities, and I quite often ask myself, is that because we're not getting it right at the beginning when they're children and young people? The NHS made a commitment quite a long time ago that we would significantly reduce inpatient provision for people with learning disabilities, and we're still not in the place where those young adults are in community and actually, as far as possible, living an independent life. We take too long to repatriate young people with learning disabilities from out of area. And we don't always have them in the right facilities either, which means that their behaviour deteriorates before they want to come back home, and then we're looking for different kind of placements for them. So there's something in my mind around, yes, how do we support our staff right across health and care around their understanding of how to support and listen to families in that situation. But I also think we've got to really, through the work we'll be doing on equality and inclusion, we also need to be really brave in challenging some of the stereotypical views about people with learning disabilities. We know they have a life expectancy of up to 20 years less than someone who doesn't have a learning disability. And some of that will be the approach that teams take around their view around the value or quality of their life, and that's wrong. So I think we need to really be honest with ourselves about why some of these situations arise, and then start to co-create some of the solutions with families that are finding it far too difficult to navigate their way around a system that we still know any front door is not the wrong front door, and we've got to change that.
Matt and Debbie, did you want to come back in to pick up any of those
I don't really think so, because I think, you know, the video wasn't to solve the issues. It was to actually raise the issues, to make people think, to actually, I think Matt's already said that actually they've taken it as a learning opportunity. But it was really just I think it's really powerful, and hopefully it will stay with us, so that when we're making decisions as a board and in our roles, it's going to be there at the forefront, because I think that was what it was there for.
Yeah.
Really.
Matt?
Sorry, I'm just going to come back and say, I mean, Paul talked about this being an individual case, and individual cases are all specific, aren't they? They're all complex, and they've got their own sort of nuances to that. But we have taken that learning on. We've shared that video with our Learning Disability Partnership, and looking at learning from that. Also, I just want to comment about wellbeing for staff. You know, that did have an impact on the social worker. We're very mindful of that. It was a unique period of time that was creating, you know, certain pressures, but we still see that, the tail of that, in terms of pressure on staff, and we take that very, very seriously. But I'm also, you know, delighted Ruben's family has also written to us recently to say that they're really, really pleased with the outcome of this commissioning, and that Ruben is in a good space and a good place. And I would suggest we talk to People First Dorset. If you want to talk to anybody else, get them in as an organisation, because they're a fantastic organisation. You can tell I've advocate for them before, but they're great, and the work they do is fantastic. But it's that learning point that is really, really important, and we're constantly learning. And that no wrong front door comment, Patricia, because it is so complex. You know. It's different. It's Terry Levy, wasn't it? Chief Executive Tesco's, who said if you listen to your customers for long enough, they'll tell you what's wrong about your organisation. But if you continue to listen, they'll tell you how to put it right. The challenge is that's in one organisation. We are multiple organisations with multiple touch points and multiple entry points, and we just need to be able to get better at that.
I know Neil offered, I think it was in January, wasn't it, to do some work around the wrong front doors, but we'll come back to us.
It'll be part of the transformation plan, but there's a big piece of work, as everybody knows, going on in David's team, which is about redesigning children and young people's mental health services.
So there were some themes that came out through there, which we'll probably pick up as we get later into the agenda, particularly around the isolation and exclusion. Matt, you talked about, or several people talked about the VCS, but I wonder whether or not we have the same systems in place to assess and monitor burnout for people that are volunteering, because I think, you know, in the kind of formal systems, it's not easy to do, but there are processes, aren't there? I don't know how easy or not it is in the VCS section.
The short answer is it's complicated. For the larger organisations in the BCS, there is definitely the processes in place for that. In the sort of intermediate space, for the sort of constituted groups and organisations that maybe aren't formal business or a charity or CIC, there is a lot more variability, and we're doing a lot of work with our colleagues to kind of cascade the opportunities. Live Well Dorset, for instance, has some well-being services that it's offering, and we're tying that in at the moment with food banks and the volunteers that are working in that kind of setting. So where the opportunities arise and the capacity is there for people to engage, we're doing our best to kind of make that part of the picture. And a lot of it is about the kind of connecting people, so that we're not working in a vacuum. And the conversations I've had with Dawn, particularly about learning from one another and connecting in with other services to build that kind of resilience, has been really helpful. So I'm quite optimistic, but there's lots of work to do.
Thank you. And as Debbie said, it's not just about this story, it's about what we do from here, and there's various things going on. So we'll pick some of those themes up as we go through. So I will go back now, Patricia, now in the wrap up. To your Chief Executive.
I'll take the report as read, thank you, and I'll just highlight a few important points. I've referred to the Hewitt review, but we're going to talk about that later on, and we're still waiting for the government response to that, so they'll accept the recommendations. We sort of moved past the point at which the paper was written around industrial action. As you know, a significant number of unions have accepted the Agenda for Change pay deal. We're still, the NHS is the Department of Health is still negotiating with nurses and junior doctors, and I don't think we should underestimate just how important those negotiations are, because whilst a million staff represented will receive the agenda change pay uplift, you can't actually deliver a huge proportion of service without junior doctors and nurses. So the operational plan that we've submitted to NHS England does not take account of any industrial action in the future, because we don't know what is likely to significantly impact on our ability, particularly to reduce the elective backlog. I would like to thank local authorities and our third sector particularly, because having implemented on the 1st of April our new discharge process and the additional capacity that's required within the discharge to assess service, we've seen quite a big reduction in our patients that should no longer be in hospital. So that's been good for them, and it's good for our system, because it means our bed occupancy rates are much lower, which means that we're not going to be running an unsafe system because of inefficiency and high occupancy rates. The NHS staff survey was published for NHS organisations on the 9th of March. As you recall, that as an ICB, in terms of positive scores, we were second in the National League table, which is a real positive. Some of our staff survey results now for our NHS partners are really good. Just want to remind everyone that we did agree at a previous ICB that we would take a single approach to equality and inclusion, and we are going to move forward as an ICS with the first stage of that in terms of leadership development and policy development over the next few weeks. Just quickly bring you up to speed on where we are in terms of the barge that will be arriving in Portland in June. We have now got the semblance of an agreement around health provision, and we'll start some conversations with the regional health authority about helping us fund the work that we'll need to do to define that service offer in detail. The expectation is that that barge will be here initially through a licence for 18 months. We will await further instruction from the Home Office in terms of the next steps. We have met with the Home Office a couple of times now. Having worked in Bedford for a number of years next to the Yarlswood Detention Centre, some of the conversations with the Home Office were around particularly my experience of working in that system and what we need to do around mental and physical health screening when those people arrive, and if they're being transferred from other areas, hotels, to make sure that's done. If they're from war-torn areas or challenged communities, the likelihood is there may be a high degree of PTSD, and we want to make sure that we've got the right systems in place to support them if that's the case. The integrated care system operating model, we had a workshop with partners several weeks ago where we looked at the first draft of the model. We are having another session with chief executives next week, and I'm hoping that at that session we'll be able to land the core elements of the model and then finesse that to come back to board for sign off. The ICS operating plan, or the ICB operating plan, which is predominantly health, we submitted that within the agreed timescales that were set by the national team. We held a meeting with the national executive on the 24th of April. I think it's really fair to say that they've got a lot of confidence in us now because we delivered the things we said we would last year. The meeting was really positive. Yes, we have some challenges, particularly around the finances, the fact that around 50% of our financial plan, I think, is based on non-recurring savings. And we did say we would do some further work on trying to reduce our exit run rate in 23-24. We also committed to doing work across the system to make sure we've got a medium-term financial plan by September to discuss with the national team, accepting that it will probably take us at least 2 to 3 years to get into a fully recurrent, balanced position, and we can start then to invest in services that we want to improve at a higher level. And I'll leave you to read the updates on each organisation. There's some really positive things in that section, and I'm happy to take any questions.
Thank you, Patricia. Any questions or comments?
In 4.1, we talk about the joint forward plan. How is this going to be shared with partners for input and comment before submission, particularly health and wellbeing boards? How are we going to do?
So we are where we've got to at the moment is the 5 objectives that are sat in it were developed by the partners. So we've had a couple of workshops at the RNLI to look at that. We've got work to do now to engage the health and wellbeing board chairs to make sure they're comfortable with that. What we've tried to do, Spencer, is, and we're going to pick this up in part 2, I think. What we've tried to do is have a set of objectives that sit clearly under the integrated care partnership strategy. So what we're not doing is having one set of objectives for the ICB and something different for the wider system. So we will be bringing the 5-year forward plan back here before we submit, or circulating to partners before we submit the final version of it. And then there's something about how we manage the governance arrangement. I think in my head, which we're open to a conversation about, is the ICP needs to monitor it. It's got to hold the ring on it, because the 5 objectives are more about the wider determinant. It's not just solely about health, but we have a responsibility here to pick up the health elements and make sure we are pursuing those. We've had as an executive team, we had a workshop with Brown Jacobson last week to look at how we develop a board assurance framework for the ICB. And I think we were all clear that those 5 objectives, the strategic objectives, are what should form the meat of the board assurance framework around the strategy. And that for the ICB, the board assurance framework, which will come every other meeting, is the way that we'll monitor progress against those 5 objectives, particularly focusing on the health components. Does that make sense?
Thank you. John, before I bring you in, can I just check that on the screen you can actually hear everything clearly as we're going through?
It's not bad. Patricia's a little bit quieter. I think the Patricia's side of the room is a little quieter than Jenny, your side of the room, but it is okay. We're picking it up. It's that would be my view. I don't know if others think.
Thanks very much. Thumbs up also from the others. So John, do you want to go next, and then I'll bring Dick?
Well, first of all, just to thank you. I do find this an incredibly useful report, and I'm still left with the comment that Lisa made earlier on about people run through the experiences we provide to the people of Dorset. And I just wanted to really acknowledge, thank you for I think the way in which we handle and support everybody's right to take industrial action, but also keeping and providing safe levels of service across the region and through all our providers. It's an immense focus. I can really see that, and just thank you for the team. It's unprecedented, I think, the level of focus. The build on that then, of course, was, I think, the staff survey results. I mean, in the first year of the ICB operating, and with the amount of change that we've got going on, really encouraging to hear that, and the determination to put that at the top of the list, that really came across. So thank you. I mean, to everybody who is taking a role on that and really listening to our teams. I think the third thing as well that I would, even in these times of the urgent work we need to be doing, I was really encouraged to see the medium and long term focus around our operating plan, where we are on the strategy. And actually, I think that is pivotal for us as an ICB. I think that is where we need to be operating, balancing the important with the, and of course, delivering on the urgent matters of the day. So I found it a really useful report across the piece, but it's really that balance of it, important and urgent, coming through, all underpinned through our teams, was I just wanted to really acknowledge everything that everybody's doing. Thank you.
Thanks so much. Debbie, then Forbes.
John's more or less stole my thunder because I was just going to say about the industrial action, and I just wanted to say, yes, we've still got some uncertainty ahead of us, but just to acknowledge everyone's really sort of hard work from within the providers to maintain as safe a services as possible. And I think it is as safe as possible because we do know there's risk there, and some of that risk and some of that potential harm might not come to light for a while down the road, but also to acknowledge Dean and his team and the sort of incident control centre that's actually being sort of established, that is really helping to keep to support providers and to keep that sort of overview of plans and what's happening during each day. And it's getting slicker because there's been quite a lot of use, but yeah, really sort of wanted to make sure that was documented. Thank you.
Thanks, Forbes.
Okay, thank you. So yeah, I mean, industrial action is very concerning, isn't it? Of course, and I think as much as can be done has been done. The apparent discord that's playing out in the public domain is just not good, really, is it? It's just not helpful to anybody. My other point really is just about this before is always hugely helpful, and if you read through, there's just it's around estates, and it's sort of links to the point I made in my previous presentation the other week. But we've got a long list of estates investments, many of which have been nationally driven, and these estates investments are largely in acute services. So we're talking about our plan and our longer term strategy, and we've got millions and millions and millions of pounds. And I'm not saying it's not needed, it is needed. We've got a discharge line, we've got ED, we've got St Anne's, we've got the development of UHD, we've even got a helipad, and we haven't got £1 mentioned about an investment really in an out of hospital model of care. And I think in future reports, we need to balance that, because that's what our strategy is. And anyone who's not working in that acute setting thinks, well, I'm struggling to get a room for my physiotherapist or my pharmacist or my GP or whatever. And, I think we've got to just be aware of that in this reporting and in our strategic direction for our estates investment. Another point just to make briefly, and I welcome the reporting around the collaboration between Dorset County Hospital and Dorset Healthcare. So I think that sounds positive. I think we also need to focus on the wider clinical collaboration. So we've got to look at a single acute network of services where that's appropriate, because that's something that we've wrestled with in Dorset over many years. And I would just ask that when that piece of work goes on, which I fully support, we make sure we've got the impact assessments alongside it, because sometimes we do these transformational pieces of work and we haven't considered either the effect on our population or the effect on our partner organisations as well. So that's all I would ask in that piece of work. But I absolutely support the concept.
At our Dorset Chief Execs meeting this morning, we agreed that we had 5 strategic objectives we would use. Neil's trying to think of a more fantastic phrase for this, but strategic portfolio management. And the reason why we're going to use that to manage the programme is because it does exactly what you just said. It helps bring to the fore in a more transparent way what the flow and impacts would be of any decision to change service. So we're going to use that because that's been a weakness, I think, in the past. I think in terms of the out of hospital model, the work that we're doing at Place, it will help with that, but David's also started a programme of work with partners and some external support to start the work on transforming the out of hospital model. What we had talked about this morning is how we bring to the system executive group at the next meeting and then eventually the board just an update in terms of briefing paper on the remit of the provider collaborative and what its work programme is going to be, and also the same for Place. And then we're getting a much clearer view of the 2 main delivery mechanisms that the system has and what its remit will be going forward in the context of the strategy. Just back to the question from Spencer, what we also agreed was for each of those objectives, rather than having a single SRO, we'll have a 4-way partnership of an exec from the ICB, someone from health provider, someone from local government, and a third sector lead in terms of voluntary sector. In partnership, will hold the ring on that programme of delivery, because we really are talking about the partnership. And I think that means that we're creating a system where everybody's got skin in the game in terms of the outcomes and making sure the community is at the centre of some of those decisions. Rob's going to start some work on a estate strategy for the system, because as you know, Forbes, all the things that are listed in this paper are funded by the New Hospitals programme, and we need to think about what's the broader estate plan. And you remember at one of the ICP meetings, Philip Broadhead raised the fact that we really need to be moving to one public estate and getting the best use out of the estate that we've all got collectively. So we'll be picking that up with partners and looking at how we can make the best of that in terms of not just facilities for care, but also the broader, wider determinants and how we address some of those. And actually, this morning we were talking about place development and giving the Chief Executive an update on that. And what was really powerful in the BCP area is the first programme of work that's come forward that they want to concentrate on is 600 people who are not living in appropriate accommodation, temporary accommodation, which will have a huge impact on their health and well-being, and what can we do to address that. So I think we're getting into the place now where we're focusing on the right things.
I'm going to bring Matthew in, and then I'm going to move us on.
Thanks, Jenny. And I'm conscious that I think I know most people, but it's the first one of these board meetings I've been to.
Is it your first board meeting?
Yeah.
Apologies, I should have allowed you to introduce yourself then. So can you do that? And then apologies for that, Matthew.
Not at all. So I'm Matthew Bryant, and I'm the Chief Executive across Dorset Healthcare and Dorset County Hospital. So very new to Dorset, but I just wanted to pick up on the points that Forbes made. So Forbes, I agree with you really strongly about both the points that you made. So just on the estates issue, and I think your point actually goes far wider than estates. So I think as we track our strategy and the delivery of it through in the months and years ahead, we need to be putting the numbers to that to keep ourselves focused in the right place and make sure that we're holding true to that ambition, which is to rebalance our system away from bed-based care. So I agree with you about estates, but I think the point is even more significant than that. And from a Dorset healthcare point of view in particular, that work to look at estates, that idea of one public estate, I think is incredibly important. There's so much more we can do. I was on Portland last Friday morning and seeing a really good example of how the hospital there is being used in a different way in a partnership with local authority colleagues, but there's a lot more we can do. And in terms of your point about really engaging all partners in the work that we're doing, whether that's about the acute to acute work or it's about the collaboration work between Dorset County and Dorset Healthcare in the west, or similar work that needs to be done in the east of Dorset in terms of the connections between community and mental health services. We've got to do that. We've got to proceed in partnership. And just one voice I'd like to describe that goes back, I think, to our patient story is, in addition to primary care colleagues in the BCSE, it's actually making sure that the voice of carers is central to that. And we've got that partnership between providers, service users and carers.
Thank you. Really helpful. So the report, Patricia, is really valuable for us, particularly as it brings together all of the things that all the partners are doing. So thank you, and to encourage partners to keep contributing because it does make a difference. I just wanted to pick up one of the things. I can't remember who picked it up. I think it might have been Debbie about the staff survey. Somebody mentioned the staff survey anyway, and just to really endorse what an achievement that is, actually, Patricia, to your leadership and the senior team. So it might not feel like a big thing, but when you bear in mind that we are one of very few systems in the country that had a wholesale change of leadership, and I mean the full leadership changed. The ICB that picked us to the post as number one had no change. So it's not insignificant that we managed to achieve that with all of the upheaval in a period of what would have been quite unsettling for staff. And then everything that's come on top of that and setting up the new organisation that we managed to achieve the results that we did. So I just wanted to thank Patricia and the team for doing that.
We've still got a way to go. We've still got some work to do, but yeah, it was a nice result after a really hard few months. and yeah, a lot of the leadership development stuff that Dawn and her team have done have really contributed to it, as well as good leadership behaviours from the exec team to really bring people in.
Thank you. All right, so we've got a decision item now, so I'm going to move us on to business conduct. And these have been through the audit risk place. So the standards of business conduct policy and the annual review of the declarations of interest. So Liz, do you want me to come to you for both of those?
So 2 governance items. The first one is for approval by the board. This is the revised policy on the standards of business conduct, which comes forward for approval following approval and recommendation from the audit committee. The main revision is that it's been moved over into the NHS Dorset policy template, which we hadn't used when it was originally drafted. There are no material changes. The small changes that we have made have been listed in the report. We didn't do track changes this time because it's a whole scale format change, but it's been noted that we'll do track changes for you in future for any future revisions. This keeps us in line with NHS England guidance and also with best practice. We're expecting some updated guidance from NHS England potentially in Q1, and as soon as we have that, we will obviously review the policy, but we wanted to do this now in case that update is delayed. So it's for the board to update.
So can I take indications? I don't know if there's questions or comments, but are people happy to approve? Yeah, thank you very much. Shall we move on to the declarations, which is here for noting?
Thank you. So the second paper is around the annual declaration of interest, gifts, hospitality and sponsorship. This is just for the board to note, and it's been noted by Risk and Audit Committee, who also approved the actions that we undertook relating to the internal audit, which are highlighted in the reports. At the end of the year, we've got only 13 declarations outstanding out of 600, which we feel is a very positive position. There are no declarations that we've received that have been of concern. The audit have confirmed that they've given us a substantial opinion on our processes, and our process has also been used as an exemplar of good practice through our internal auditors to other ICB. So that's really positive, and I think we can agree that I'd like to thank the team for the work they do on this, because they were in a very tight fit for us around declarations. This also covers gifts, hospitality and sponsorship. The register is linked in the paper for you, and there are no declarations of concern. One item that is outstanding for us is around training. The modules that were originally run for CCGs were stepped down by NHS England, and there was nothing put in place to replace them. NHS England are now currently working on a revised version of that training for us, and as soon as we have that, we'll roll that out to the organisation. The internal auditors are content that the regime we have in place at the moment of providing information and reminders to staff when they commence, and also covers off our training requirements as it stands as an interim measure, really just for noting.
Thank you, and it's obviously an important part of our governance, so it's here for noting, not for decision. But are there any questions or comments on the paper? Okay, thank you very much, Liz. That's comprehensive. So that moves us on to committees, and we've got various escalation reports. I'm going to go to each of the committee chairs. First of all, we've got the reports in the back, and nobody already read them, but I'll go to the committee chairs to add anything that they wish to the reports, and then we can have any discussions of that. So, Jonathan, can I go to you first, please, for the Clinical Commissioning Committee?
Yeah, so the last committee, we were getting ourselves acquainted with 3 areas where we think there'll be some commissioning needs in the future. I think what I'd like to add, I'm trying to think how to say this in a profound way, is that I think we're beginning to see a pattern where a lot of these programs are overlapping, are interconnected, and a lot of them are looking back and saying, actually, what we need to do is to solve this problem is meet capital demand. So what we're seeing is supply side solutions, which actually need demand side solutions ultimately. And I think we're beginning to get an understanding of really how we need to start moving into a more preventative agenda. And I think we're beginning to see a pattern and a way that we might need to sort of change things around and change the commissioning. But I mean, really early days, but certainly I felt for the first time, thought, okay, I can see something happening, see the jigsaw coming together here and what's not quite working. Yeah, I mean, everything is working and we're all doing their bit, but you can see how the bit needs help working better. Wasn't very profound, but that's kind of where I'm getting to as a chair, and I think the committee is moving towards. So I think that's just a sign of things as we're seeing more, getting better understanding.
Thank you. I mean, that feels like a good place to be in, that the whole of the digital sort of doesn't come together, isn't it? So, any questions or comments then for Jonathan? So, can we go to you next then, Dan, please, for the Finance and Performance Committee?
Yeah, I just take it as read and draw the board's attention to 3 points really. We had a really good discussion on what does good look like and how do we as a committee add value, especially to provider FPCs without duplicating their work. And so there's an escalation to the board about that's probably a conversation we could have across all of our committees. And that was, I think it was Patricia's recommendation that we look at that in a future board development session, which FPC agreed with. We've asked some more work on personal healthcare commissioning, just because it's one of the major risks in the budget for 23-24. And so that's coming back next month. And then we'll look at that and work out if we want to escalate it into the board or whether we can provide assurance on that to the board. And then just a thank you in there. So to land where we did on both the performance and the finance, really big thanks to Dean and Rob's team, whilst recognising that it's not just finance and COO who contribute to performance and break even, it's across all the teams. But the committee just wanted to note that. Happy to take any questions.
Thank you. Any questions or comments for Dan? I will just add mine then, which is also to echo the thanks to the full team, but obviously particularly under leadership of Dean and Rob for the finance and the performance for the exiting year, but also for the plans around the incoming year, which I know weren't easy to do, but it has marked us out as one of few systems we now have to deliver, but well done for that. Okay, so Kay, I'm going to go to you next, who covered the People and Culture Committee.
There's a lot on that we talked about that you know already about, such as the people plan and things like that. We discussed the staff survey in quite a lot of detail and dug into them in quite a bit of depth, really. And I would like to just reinforce what's been said already about how well we've done in a year of such significant change to do as well as we did, both for the ICB and the providers staff surveys, which have been also very positive in a number of areas. The key area, I think, where we felt that more needs to be done in terms of metrics to ensure that we are actually making change will be around EDI. And that's something that we need to look at in a little bit more detail, because the same issues come up year on year on year on year, and we've got to do something to try and change some of these things. And that's the key thing that we want to look at in a bit more detail going forward to make sure that we're making some improvement there. So no other significant issues, I don't think, to raise.
Thank you very much, Kay. Any questions or comments for Kay? Okay, Dan, go on.
Sorry, and it's not from the paper. It's The paper made me think about a previous board development session where we talked about general practice and future models for general practice. And I just wondered if there was anything on the future work plan about Dorset doing any work on what future GP partnership models could look like, and or whether there was any national work ongoing on that. So it wasn't in the paper, sorry, it was from I think it was a board development session where board presented.
I mean, I'll start off by saying that a lot of that conversation is coming through PCCC, where, in fact,
oh, sorry, I'm on the wrong committee. I apologise.
on
It's the acronym. Sorry, so maybe.
It's me because I'm normally talking primary care, aren't I? So if I'm
very good. It's your fault. Yeah.
So actually, that was the point I was just about to come in and make, that to thank Kay for stepping in to chair that committee. I made the assumption that everybody on the board knows, but you may not, so I'll bring it in. But the substantive chair for that committee is no longer, because Cecilia, who's with us today, in the new guise as the chair of the Integrated Care Partnership, was the chair of the People Committee. Now that she's taken up the role as the IPC chair, it means we have a vacancy, which we are currently going through a recruitment process for. And so in the interim, we asked Kay if she would step in and chair that committee, and that's partly
That's what confused me. Sorry.
So before, I mean, Kay might want to pick up your question when she introduces the next one, which is the primary care commissioning. You want to do that now?
Nothing else on people. So under PCC, I think the two key things going forward here, which will be the focus of a lot of work in the future. One is exactly what you're saying, Dan, is about the sustainability of GP and possible models going forward. And the GP Alliance are preparing a report. So I think Forbes will speak on that one in a minute, to bring to us about what their suggested models going forward could be. And the second one is the issue to do, obviously, with pod, pharmacy, optometry and dental. And there are still a number of risks there, obviously, with regard to taking over those areas. And we need to continue to address these. But we also need to now be looking at our new ways of working together as primary care in the widest possible sense, primary and community care. So those are the two key things, really, that I think we'll be coming back to the board fairly regularly. But Forbes, you're currently working on this sustainability report, and I think just about finishing it.
Yeah, that's right. So the report is pretty much complete and just been approved as of yesterday. So it will now be coming back. I mean, there's been a draft copy shared within the ICB, and the report will now be returning to those who commissioned it. Thank you. And quite honestly, the next step is about the actions that need to be taken and the delivery plan for that report. The report is not an end or a solution in itself. And so we'll be taking that piece of work forward. There are 10 separate sections within that report, and one of them is the GP operating model. So I think we do need to do some dedicated work on that and do it soon. I have concerns about the paucity of stuff that's coming out nationally, so I think therefore it's even more incumbent on us to look at the opportunities that exist locally. And Dan had a very helpful conversation with me before the board about where he could add value to that. I believe he could, and that's the sort of group I think we need to set up with a broad church of input to see what we can come up with. We have got some very competent people both in and outside of the existing health system within this room and the broader ICB, and I think we've got to use those skills to come up with some offer.
And did you want to come back on that, did you?
No, I was going to ask the question about national versus local balance and endorse getting on with it locally, but Bob's made that point. And then, outside of the board, I was saying to Bob's, with a day job hat, I'm happy to sit to try and help about models across the public sector. And so that's something that we can pick up about how SIP can help.
Did the report that you're talking about, Forbes, did that go to the committee then, did it?
No, so it hasn't yet. It's just finalised now. It's the report that was commissioned through from the ICB for the Alliance. We've had a couple of summits, and we've had lots of engagement with it. So it's just about to come back to the ICB, and the next steps will be what actions there are some recommended actions in that. It's just how it has to be received, and therefore we have to agree how we're going to implement those actions, because we do need a delivery plan.
Right. Thank you.
Just to add really to the conversation, it's so fundamentally important, the GP operating model within Dorset, that actually I hope we can have a broader conversation about it and not just at Primary Care Commissioning Committee.
Cecilia.
I was going to ask you about the dental contract. Obviously, it's been in the news.
Can I just check that people on the screen can hear you?
It's okay. We can hear you, Cecilia.
Carry on.
Yeah, I mean, just a question of how the transfer of the dental contract has gone. I mean, it's been in the news. It's been on lots of media about, and there has been a suggestion, I thought, that the contract had changed, but that was a political statement, which I don't think was correct. So just wondering how that transition is happening.
Well, I don't know if David's the one that should really answer this, but from my point of view, it hasn't got to us yet. And so we're picking up lots of complaints, and MPs are bombarding. Region was talking about the fact that MPs were talking to most ICBs demanding to know what's happening with dental, and we've only just taken it over at the beginning of April. But it hasn't filtered down, but we're looking at other ways to leverage what money we've got to try and support outside the dental contract a bit.
Yeah, I think that's an excellent summary, Kay. So we're aware the work's going on, but it hasn't reached us yet. But it's not stopping us from getting on with the things that we can influence. And we said from the outset, we saw an immediate opportunity to work on some local contracting commissioning arrangements using the funding flows that were there, that will sit alongside, not replace at this stage, but sit alongside the national dental contract. But it means we can be more targeted, more specific, and appropriately cover the costs. And we heard at the PCC, the Primary Care Commissioning Committee last time out, some of the work that's going on to develop those new opportunities. So I'm really, really encouraging. So hopefully the national dental contract negotiations will come in and help, but it's not stopping us from getting on doing some improvement work.
Thank you very much. So, Kay, had you finished?
Yes, I had. Thank you.
Any other questions? Comments? Okay. So let's move on to the Quality and Safety Committee. The report, the escalation report, is in the pack. Manish obviously is not here today. So, Debbie, did you?
Yeah. So I think I'd take the report as read. There's just a couple of things. We received a really helpful medicines optimisation patient safety report. We noted a couple of areas where we appear to be a slight outlier, but actually acknowledged the work underway around structured medication reviews and actions being taken to try and address those two outlier areas. And we will receive a further update on progress against that at a future committee. We also noted the proposed safeguarding governance architecture, which was well received and actually supports us to fulfil our statutory role to safeguard effectively as an ICB that we took over from CCG. So that was really positive. And I think our only area of sort of escalation to the board, just for noting really, is in relation to an increase in C. difficile infections of 12% over the last 2 years. Just to note that actually we're not an outlier on that. That's a national increase. Dorset isn't an outlier. Every area has seen this increase. We have developed a better tool to actually get a better understanding of what's driving this increase. We know that it's likely to have had some impact from the pandemic and the increased antibiotic prescribing, but we will bring a future report back to quality again to get a bit more detail around that, because there are other factors around sort of primary care, changes around remote appointments and all those kind of things that might well be playing into this. So we're going to try and get a better understanding so that we can try and work to reduce that across Dorset. So happy to take any questions, but that was always going to escalate.
Thank you very much, really helpful. Any questions or comments for Debbie? Jonathan.
It's one, I've been looking at it a couple of times now, but on the adverse events overview, there's the calls group, care delivery. Last year there were 3, this year to date there's 13. Is there anything causing that sort of jump, or is anything?
Are you looking at the quality report data?
Quality,
Yeah, so I'll come to that later.
Yeah,
That's okay.
like ahead of everyone.
Yes. Way ahead.
Okay, so that moves us on to written audit. John, I know you've got to step off because you're interviewing, but I think we've got you just in time. So.
No, we have, and thank you so much. So yes, we met as a Risk and Audit Committee on the 20th of April. I'll take the paper as read. There was nothing that we had to refer to other committees, and there were no significant issues for escalation. Just a few things to point towards. So of course we go into quite an intense year-end and planning activity. So we received papers on from Rob on some matters of key management judgment for the year-end accounts. That was really useful. We spoke a lot about some of the readiness in terms of annual plans looking forward around internal audit, external audit. Good conversations there, I thought. There is reference in the notes around the completion of an independent audit review of mental health investment standards. I think successful completion refers to the fact that the process has ended, if you like, that we will pick this matter up later on in part 2. There may be some external disclosure alongside the findings from that audit that we'll pick up in part 2. But good conversation, and I'll leave it there, Jenny.
Thank you very much. So any questions for John? Great, so that completes our escalation reports. Oh, sorry, David.
It's a general comment. No, it's not for John. It's just a general comment about how useful I find these escalation reports. Clearly, I know the ones that I'm directly involved in, but when I sort of read about the other work, it's really good. It's a really good setup. I heard this brilliant phrase this morning about jargon monoxide. I give to credit to whoever said that, but it doesn't have any of that as the point. I think it's really clear, and if you're not in the conversation, you can pick up what's going on. And of course, it gets to the point. There'll be times in future months where we have some knotty issues that flow out of it, but I think they're really, really helpful reports, and I just wanted to sort of acknowledge.
Yeah, thank you, David, and it's probably a really good time for me to thank Liz and the team for doing that, actually, because it was their suggestion, and it really does give a flavour of what's gone on in the meetings, doesn't it? So thank you very much for that. John, I know you wanted to come back in, and then Patricia.
I was going to say the same thing about Liz and her team, and both the quality, but the timeliness of that, and just the assistance they give to us. But I think it's to all of us as chairs of those subcommittees. Really value their counsel and clarity of thinking.
Yeah, thank you.
Thank you for that. Liz is having her appraisal tomorrow. You send him a note, Liz.
You paid us £5 earlier.
I was just thinking that it's a sort of is a good precursor to the workshop we're going to have in June, because one of the things we did realise through some of the conversations, or crystallise more, is that all the work of the committees actually overlaps and is connected to each other. So when we have the workshop in June, it's quite important that we think through that, and when we do the committee work plans, where we should be having shared objectives, where there are really clear connections, and then be clear about who's monitoring what.
Yeah, agree. Okay, thank you. So we can now all catch up with Jonathan and go to the quality report.
Harsh threat.
So obviously you've got the quality report in front of you, so I'm going to take it as read, and hopefully you've had an opportunity to look through the details. So just a few things to escalate. So obviously section 2.1 outlines that University Hospitals Dorset has now had publication of their CQC report. I think we had a detailed discussion at the Quality Committee, and I just wanted to highlight that that the Trust are now getting on with the improvements required, and remedial action plans have actually been sent to the CQC. With regards to maternity, the progress against that improvement journey will actually be monitored by the Local Maternity and Neonatal System Group. So the report's links are there if anybody wants to have a look. Don't know whether there was anything you wanted to say, Siobhan, on that, or
just to make clear that the immediate actions have been undertaken and completed.
Absolutely, yes, thank you. 2.2 just sets out the new CQC approach to assessing local authorities and integrated care systems that came into effect on the 1st of April. Gives CQC the new powers to do independent assessment of both organisations and the integrated care system. Some pilots are happening between April and September, but there's not in Dorset. So just to let you know that we haven't been chosen as a pilot. It's going to be glad to know, I think. So hopefully the learning from those pilots will actually then inform the future inspection regime and framework that they're going to use from September onwards. So we've got a bit of a reprieve. We're quite often a pilot, so we do volunteer quite regularly, but we're not on this case, so that's good. And we can actually see how that plays out from September, and I'll bring back information to the board as soon as we know when in Dorset we're going to be a part of that inspection regime. I think the serious violence duty section just shows you that we are compliant with what we need to do at this precise moment in time. There's a section in the patient safety around 3.1 which just sets out how we have done our assurance checking with our annual patient safety audit. And then the report, also in 3.4 sets out how we're sort of progressing with our PISA, but also across primary care and rolling out a national learning for patient safety events programme across our practices, which has been received well and is being progressed very well. And then the last section of the report, we tried to add some sort of real positive progress that we're making around some of our digital programs around helping our population to self-manage their long-term conditions through the My Health Act, and there's some good data in there around the success of 6,000 licences being provided and some of the outcome measures and impact that that's actually had for patients that have actually used the app and it's had the benefit of which is in the direction of travel that we want to go in, moving to that more sort of prevention, self-help, and so we thought we put some impact in there and some outcomes of the early work that's been done in that area. So yeah, happy to take any questions. I've got one question.
Yeah, you have. Do you want to?
You were asking about the adverse events, which is the first data in the detailed data, which is at the back of the report.
Yes.
I mean, I think the first thing to say is that, I don't get too worried about incident and SI reporting as such unless we have really high themes that are taking us off kilter, because actually high reporting organisations are safe organisations. I think the only thing that does have an impact, and I think it starts to show out on this graph actually, is that when the hospitals are at their busiest, so potentially across winter, you will see an impact on more serious incidents, and you see an impact on sometimes on pressure ulcers, but definitely on falls. And I think the data sort of demonstrates that to a certain extent. But we do keep an eye on it. We keep an eye on it on month by month, but also we keep an eye on themes and make sure there's not learning that actually from a previous incident hasn't been embedded and further serious incidents are just being repeated. Is that what you were asking then?
I was probably asking a little more deep because I was wondering if there was any context or pattern in that care delivery increase or anything that's just why it would be higher. I also, there's not enough to compare it against. There's only 1 year to compare against, so that would be 14 last year. The clause group.
Yeah, I mean, no. I haven't got anything. I mean, other than the fact that it could have been coded differently. So obviously, when we look at the SIs, we don't just look at what they're logged at. We look at the whole RCA and we look at the learning from it. Without going into the details, Jonathan, I don't know, but I've not seen any sort of themes coming through that have been an area of concern that has that's not been where the learning hasn't been embedded. So I can try and find out. That's helpful.
Thank you.
Right, any other questions or comments, Debbie?
Debbie, just because I was looking at the detail actually, and obviously, you know, the degree of pressure, and I think Debbie said it earlier about rounds of industrial action and impact actually, which I think we will learn more about as time goes on. But I was just looking at incidents by site, and actually, Royal Bournemouth's not listed, but Poole is, and that just seemed a little bit odd. So I just wanted to flag that.
What page is that?
It's in the report around the quality overview adverse events, incidents by site or department.
I don't know why that's not on there. I'm sure it's on previously. I'll double check that for you, Siobhan.
Thank you.
Because there are none.
Well, there definitely are.
I really realised that happened.
Yeah. Okay, I thought I saw another hand. Okay. Right, so two things to come back there on, Debbie, but thank you for the report. And that allows us to go to our break. So if we can take 10 minutes, so if we can be back at 42, please, 47. So you've got 11 minutes. put us live? Thank you. Thanks, everyone. So we're now going to move on to the performance report, and Dean, I'll go to you to present.
Thank you very much. I suppose the theme of the performance report is very much continuing on the journey that we've been on recent months, kind of a continual improvement in just about every area that we've got, which is really good, and I'm really pleased to report on that. So in terms of some specifics, on the waiting list, we continue to reduce the number of long waiters that we've got. We ended the year at the end of March on 116. We do expect at the end of March, which we have passed when we get the final numbers, will be slightly increased from that, mainly due to industrial action that we received and experienced during April. There will be reduction kind of at May. We're looking as if there might be about 86 people over 78 weeks at the end of May, but coming down to probably around 0 at the end of June. So we're on that journey to get to that. Obviously, the new one we start to track is 65 weeks. They're the ones we're trying to get down to 0 by the end of March next year. We continue to improve on the cancer standards. We've already been at the target at Dorset County for the faster diagnosis standard, so where you get a diagnosis within 28 days, and the data that we are about to report for March will show that we're doing that at University Hospital in Dorset as well. So both at the beginning of the year meeting the standard that we're expecting. So what this will do is allow us to kind of go further during the year and improve on what the national minimum standards are. In diagnostics, again, we continue to improve on the long waiters there. Still got problems within 3 pathways, which are mentioned in the report. And we're making some progress with those. The one I particularly wanted to pull out was on urgent emergency care. And I suppose reading this report, I'm really looking forward to the day where I don't have to start the report where it says the biggest problem that we've got in the system is our no criteria to reside. So we, back in September, when we were first kind of reporting on this, we were over 360. As at yesterday, we were at 263. This is the position that we were expecting to get to by the end of June in our operating plan. So we are there ahead of time, provided that we continue to sustain that. And there's no reason why we shouldn't. There's been a lot of work put into how we achieve that, and most notably the discharge to assess pathway and the new pathway that Debbie's team and others have helped us with to design and are now putting in place. So that's a real big success. And it means that people are not staying in hospital when they don't need to be as long as they need to, which is a really good improvement. One of the things that I really want to mention that has been a success is something called a MADE event, which is a multi-agency disciplinary discharge event, which I think in the Dorset system.
Not mad.
No, MADE. They are MADE events. They are not mad. But they didn't have very good press kind of last year or up to last year. But what we've done this time is because they were usually used as a reaction to kind of problems within the system. We've now moved that to being a proactive element to it, planning it well in advance, and we're getting some really good feedback from it. We did it in the community hospitals. We reduced the no criteria side by half. We went from 60 to 30 in a 1 week programme. UHD, you've just started to do that, and I think the learning from it is that, well, actually, what we've learned from that is kind of this is the way that we should be working anyway. And I think what we do from that is actually bring into our normal work in our business as usual processes things that are good practice and have only been done in escalation in previous times. So it's improving the way that we work rather than having to do things. The next stage of this will be to start tracking our operating plan for 23-24. Which we have signed off, and you all signed off kind of at the Finance and Performance Committee, and it's on the papers for today. So I'll leave it there now for questions.
Thank you. Siobhan first, then Jonathan.
I just want to make a comment, really. I mean, do not underestimate the impact of what Dean has just described, because actually, in terms of flow through the system, it has such a beneficial effect. And we were just talking about adverse events. all of this is interrelated. So actually, in terms of staff experience, working in the emergency departments or on the wards, from my perspective, but all of this has an incredibly positive impact. And there's been real progress, which is great.
It's real progress. It's not kind of reporting progress. This is real progress.
Maintain.
And we need to maintain it. Absolutely, we do. And it's a collective approach that we've had. I think mirroring the way that we signed off and developed our operating plan. It's based in service delivery. It's based on people and what they're for.
Jonathan.
I'm going to sound slightly churlish given the real progress that we are seeing, but are you in any way concerned about what seems to be rises in the 52 weeks waiting lists over the last 3 months? Does that upward pressure concern you?
It's something to keep an eye on, certainly, because we don't want to see that going up, because that's the overall kind of numbers on the waiting list. We need to start seeing things down. That's one of the things that we weren't able to sign up to in our operating plan, because we were expecting to see a slight increase in the total number of patients that were there, and obviously we're seeing this at the moment in the 52 weeks. So it's something we are keeping an eye on and kind of report on in future months. Yeah, good thing to point out.
Matthew.
Thank you. So I think that there's been excellent progress in terms of the no criteria to reside work in physical health settings. Huge thanks to all partners involved on that. Can I advocate, please, for parity of esteem between paragraphs 2.17 and 2.22 in the report? So I know we've got some main events in mental health settings, and I think as we go through with this report, we should be trying to quantify the delays in mental health settings as well as
It's the stage that we're moving on to. I think, Debbie, do you want to take the story there?
Should I just come in on that? So absolutely acknowledge that, and we're starting our mental health ward visits next week to do the same that we did within acute trust with a mental health focus. So we're actually putting fresh clinical eyes, if you like, on visiting all of the mental health wards to actually try and see whether we can identify where our sort of areas for work are, where our gaps are, and what some of the themes are that are actually causing delays in mental health. So it certainly doesn't address what you're saying, Matthew, but does actually sort of assure the board that we're not forgetting mental health, and we're absolutely on it from next week.
That's great. I know there will be lots of learning from that, which will be about internal organisational processes, for example, within Dorset Healthcare as well other pieces of learning.
Yeah, and I'm sure there'll be some system learning as well across partners, local body colleagues. So yeah, definitely come more about it.
Trisha?
Probably going to hex myself now by saying this, but it's felt really positive for the last couple of weeks. It feels like we've turned a bit of a corner. Don't you dare bring everybody down.
He's on next.
He's a CFO, that's why. Even on the money, just before he says it, yeah, we've got some challenges and we've got some risks, but the partnership is really starting to solidify, and that's why I think we had such a good discussion with Amanda Pritchard and Julian and David Sloman in the national team. Things are really starting to come together. People are really starting to do what's in the best interest of the community, and we're all sharing the risk between us. So it feels really positive, and we can just really build on that now when we start to do the transformation work for the 5-year forward plan, because it's starting to feel really good. And I just want us to acknowledge that everybody works so hard to get that operational plan together, and not just health partners, colleagues across other parts of the service as well, because on other sectors, because obviously we can't deliver anything in health without everyone else. Not one single one of our patients only touches one sector. So it really was a joint effort, and it felt really positive, and it also felt as if NHS England had really got a sense of confidence in us. which is why we didn't have, a micromanagement meeting of every number. We just had a general discussion about the direction of travel. So we just need to keep going, to be honest. We've created a good relationship, and it feels really positive.
Thank you. Forbes.
Yeah, that is just really to commend the progress that's been made. So it looks like, moving in the right direction. Let's hope for no other major interferences. Sort of operational service delivery issue. I think there is still an issue around dermatology at DCH, particularly in the advice and guidance service. We've got, I think, an inequity of provision across Dorset. I see UHD have appointed 2 consultants. It's identified in this report at DCH. In recent months, it's been taking, quite frankly, several months to respond to advice and guidance. Now, the reason these are sent in are because they're query cancer, potential cancer diagnoses. So, I have had assurance from Alistair that they are looking at it, but so far there doesn't seem to have been an outcome to that. I know I've raised it a few times. I just think it's sort of running on too long without having some sort of a remedial plan in place. Because, at really practice level, but shared across West Dorset, suddenly you're probably having to send patients into the clinics that have been managed that other way, because you can't wait, because you don't know when your response is going to come. And back to the point we made in the earlier meeting, if we've got a single acute network of services, sure, they can work across East and West and come up with something that might improve that difficult situation. Another point I wanted to make, and it's a really small point in the total performance, it's under 6.1, it's healthcare worker vaccinations. And it's just that the Dorset workforce is a bit lower than the rest of the South West in terms of vaccination for flu and for COVID. And I just wonder going forward if there's anything we should be doing to further encourage our workforce to have it. It's a marker, isn't it? And it's quite an important marker, really. But we are below the Southwest average. It's 17 Southwest is better than the rest of the country, but I don't know what that figure is. I think it's something we should just be, mindful of.
Ian, did you want to come back on?
Yeah, you're right, Forbes. It's something that we need to be mindful of. We are kind of really below the average for the Southwest, but the Southwest kind of is the best across the country as well. So, but we don't want to kind of drop further down. So we will make sure that there is a continual focus on that for next year.
When we talked about dermatology, we've just agreed formally the remit of provider collaborative discussion this week around how do we prioritise the services that need transformation based on sustainability or access issues. So it feels like dermatology is a good one to pick up.
I think definitely it would be wherever I've gone in my working life over the past 15 years, there have been the same issues with dermatology services, which largely relate to the increasing demand that we are seeing, particularly in this part of the country, alongside notwithstanding very good work locally in places, a national workforce plan that hasn't been in the right place and hasn't delivered with dermatology consultant staff in particular. So I suspect, I don't know the detail of the service in Dorset County, but I suspect that the workforce problem is quite challenging, and I think it's the provider collaborative is exactly the right place to have the discussion.
I'm just looking up now, and just so that we recognise these things when we see you bringing them. What are the critical dependencies or critical activities that really need to continue or happen over the next 12 months in order to sustain what we're seeing here, to sustain the improvement, sustain any build on it?
In any particular, I think it's looking at some of those other indicators, like Jonathan's mentioned, kind of 52-week total waiting list. It's not just looking at the headline measures that we're monitoring. It's looking at what's going on underneath, and kind of we do some of that. The trust do it in much more detail. So because we know that kind of where we are today is not where particularly long waiting. So I think it's looking kind of further down into and what our strategy is in delivering the strategy. These things that we're monitoring here are largely kind of the minimum targets that are handed down during the
Just add up, I think we need to be relentless about it. So, you know, from a trust perspective, we're embedding patient first, which is quality, continuous quality improvement. And we've built in some of the measures that Dean has described. And actually, you know, as a system, we've got to be relentless together.
Culturally, that's a real challenge.
Yeah.
So you know, it'd be interesting to see what we could do to help with that, because it is really important.
Sorry, just another important dimension is that, in that Jonathan alluded to it earlier, is about managing the demand and changing that focus as early as possible. So key focus of our strategy around early help and thriving communities, all that will feed into this. And I've used this example a couple of times over the last couple of weeks, actually, which is around, we approved in this board a business case for a hyperacute stroke unit. And that was a few £1 million that we signed up to, but that's for people who are already ill for an illness that is totally preventable if you do the right things at the right time. So if we don't do anything, we're having to build £3 million extra space and capacity and all the other things. It's obviously important that people are ill and they've got those facilities, but the best way to avoid doing that on an ongoing basis. And I think I'm nicking Neil's interpretation, which is if we don't stop, we'll just keep building bigger and bigger car parks, because that's what we're going to have to do to service the hospitals. So that's where we've got to go, and that's why our large portion of our work, larger than it's been, I think, in a generation, is going to be focused on the early help, prevention and thriving communities work, which is everybody here. And
so that's a really interesting balance, isn't it? Because on the one hand, you're saying we need to dig into those current operational anomalies and understand why and bring them back up. And we've also got to be kind of looking up and out at the bigger agenda and the longer agenda. So it's a tricky balance to strike that. And it's important that we call out when we get that balance wrong.
Yeah. And it's also the measures for that as well, isn't it? Yeah. So this report has definitely developed from the start. And one of the things I remember you talking about, Dean, was not having any measures for primary care and going away and developing that. And we now have some of that, don't we? I guess I'm not clear what the primary care measures are saying. So I accept that this is ongoing work and it's still developing, but the percentage of face-to-face appointments, as an example, has gone up. Do we see that as a good thing or a bad thing? You know, are we wanting less face-to-face or more? And I could say the same with urgent appointments. So I guess there's something about how we ultimately link the ambition and the prevention agenda with the data that we're seeing on a regular basis.
And I think we'll see this coming into its own, particularly when we've got the measures that we're looking at to monitor the ICP strategy and the 5-year forward plan, because they're the things that will get us kind of upstream, but could take years to actually deliver. So it's kind of the top down and bottom up kind of approach. You need to come at it from both ends so that you don't focus on one or the other and kind of somewhere that needs to be.
I think there's something about when we do the work in June on the committees. There's sort of a few things. There's what you do in the report. We talked before about primary care dashboard having something a bit more realistic for mental health and community. And how do we feed all that in so we know what's happening? And how do we start looking forward in terms of predicting what's happening, as you talked about, rather than taking a retrospective view. But when we start to look at the committees in June, I think we've got to really think through really carefully. Yeah, we'll have the BAF to do the strategic objectives, but we also don't do enough detail here on prevention, early help and health inequalities and equity. And even though there is a lot of work going on, and now that we've got this new member of staff who's a Deputy Director of Health Inequalities sat with Paul, we need to think through the committee structure and where does that sit. And we might choose to rename them all and have a slightly different focus, as long as we're doing all the statutory things. But we need to have a place where we really are. We'll see what the context is for Dorset, but also
And there will be some bit also about the linkage to some of the other boards and committees, weren't there? Because we know, for example, UHD have just set up a committee on that. So, okay, I'm going to move us on. Paul.
Well, I was going to say that early conversations with my new, so it's Anita, is the new deputy director, and she comes with both NHS and public health experience. So I think that'd be really valuable around health inequalities. But we're talking about, and it'll feed into the the 5-year plan and so on, in a similar way that we've got operational reporting about our performance. We talked about what it'll look like to have reporting on our performance with regards to, when it'll be health inequalities and prevention come very closely together. We haven't got reporting on our core 20+5 for adults and children, and yet they've been around for a long time. And so to bring that reporting in, and I was actually going to pick up with Patricia where that is held, where's the oversight, where's the committee oversight of that. So we do need to think that through. But I would be really keen to see, because I think it is a statement of our intent and our approach if we put as much weight on that as we do on the operational reporting. So I would like to see both being incorporated in the way that we report our performance on a regular basis.
Ultimately, that's the prize, isn't it? Because that starts to tell us whether or not we're on course. So, okay, thank you. Lots of discussion around that. Let's move on to the finance update. Rob.
So I think I've been given my cue, haven't I?
You bring us all down.
And this is the easy one, because normally
this one should be.
So normally I'm always telling you about we've got a risk, we're not, we're going to try and we will promise, but we've got risks, and I always have to tell you the risks. But this is about month 12, and we've done it, haven't we? So we've actually delivered it. We did deliver a balanced ICB position and system position. Had to move a little bit of money around amongst partners, which is great because it just shows that we work as a system as well. It was 10 months and 3 days ago. I always remember John did his famous Polaroid moment where he just said, look, when we agreed that plan, and I can remember at the time walking in on a 40 million, I think it was, that we were talking about. Guess what? When we talk about the plan for next year, I'll go back to type and we talk about the risks that are in the plan. But there were some themes that we successfully covered off, kind of operationally and money as well, which will roll into 2024. So the main things are clearly there were operational pressures that we had to handle. There was inflationary pressure as well. We had quite significant inflation last year, which we this year coming. Efficiency programs, we had to support the position for a lot of non-recurrent. I've come to the board previously and sort of explained how the ICB had to an awful lot of money actually to help balance off not only its own position but the system. And agency spend as well. Agency isn't such a problem in the Dorset system. There's lots of systems in the country. However, we did have a plan to reduce it down to 25 million and we spent 52. So we missed it by a long way, the plan. In the plan for next year, there's a cap. You only have to spend 3.7% of your total expenditure on agency. Our plan is to spend 3.2%, so it's lower. So it's still stretching for us to do it. But if we had an ambition to get down to 25 and we sort of put our finger out, it should be quite doable. In terms of the ICB, this is the ICB board. So the bits that we cover, not the stuff that's not in the providers. We only spent £6 million overspend on independent sector providers, mainly in ophthalmology was one of the big drivers of that. Personal health commissioning, Dan's already mentioned it, that we're going to be coming back at finance board's plan. For a couple of years now, it's been funded at outturn and growth on top of it. So last year, even with a funding at outturn and growth, it was still overspent by 16.6 million. And prescribing also overspent by £8 million. So they were our big cost pressures in the ICB. The only other thing really to point to is I'm quite a visual person, which is strange for a finance director, not tables and things. And there's some cogs in there because it's going to be the annual report, so it's much better for you to see. And the big cog in the middle is how much we spend on secondary care, and then you see the other cogs as well. So I'm doing a quick calculation because I love the 80-20 rule. And I can get to 80-20, so you're saying that, we spend just over half our money on secondary care. We spend about 20% of our money on primary care, and then we spend about 10% of our money on mental health as well. And then the rest is dotted around all the other bits and pieces as well. We know we've got to be doing a medium-term financial plan. we've already been talking about shifts into prevention and things like that. So as we work through a financial strategy linked to everything, that's the sort of cogs that we want to start working out how big the wheels need to be in the future, keeping some the same size and expanding some of the other ones. Not saying taking money off you, Siobhan, but that's the sort of thing that for me is what we need to start really getting into. So again, at the national meeting that Patricia talked about, we have got a commitment that we'll have a medium-term financial plan by the end of September as well. Okay.
Yep. Okay. Any questions or comments for Rob?
I'm going to go back to my thing. I think the COG diagram is really illustrative of the problem we've got. So, although Rob phrased it as taking money away from the sector, actually what you want to do is create a situation where you don't need that money. So you should be putting money, making all the other ones bigger so that the other one becomes smaller. And that's the challenge that the NHS has never been able to do, because it's always doing the middle bit, which is why Dan's always trying to sort out his electric care and things and things like that. It's and that's the paradigm we've got. How do you shift that? And it's hard.
Okay, so Dan and then Matthew.
Just to briefly jump on the COG bandwagon, because I really liked it, and it made me think about a conversation that Kay and I had, and it links to what does good look like. Because you tend to get these diagrams retrospectively in annual reports, and as we think about the performance of the finance dashboard for this year and the 5-year plan, how do we pull some of that thematic reporting into it? Because we tend to report finances and projection by organisation, but how do we overlay that with wherever we spending the money? How do we get secondary care to need less money because of the prevention? And so I think there's some work where FPC can help about how to bring some of that through to in-year reporting as well as retrospective reporting. So not a question, just a comment.
Yeah, no, that's fine. Matthew.
Keeping going on COGS, if you were to map patient volumes and draw them as COGS, the pattern would be completely the other way around from what you've got here. And I can't remember, Forbes, you might have a figure in your head, but I can't remember what the gearing ratio is for urgent care between primary care and acute care, but it's something like 1 to 100 in terms of attendances at ED versus urgent contacts within primary care. So if you get a kind of 5% failure rate within primary care because of workforce issues, etc., the impact elsewhere in the system is massive. So I think this is exactly the sort of thing we need to be thinking about when we look at things like our emergency care strategy and where we're going to put investment in the future.
Is that would it make sense, Dean, for you and Rob to be working together to see whether or not you could come up with a diagrammatic depiction that captures that last bit that Matthew was just talking about?
Yeah, okay. I think that's exactly the sort of thing that would be part of. So although you would call it medium-term financial plan, actually it hangs off all the work we've been doing. It's the famous 5, the objective, and that will be your channel shifts and showing this is where we start, because the money hangs off. So it will be part. So I don't want to say it's a medium-term financial plan that's going to have all of that, but the medium-term will be informed by all that. So actually what we're talking about is having our strategic plan with its elements in there about what we're trying to do. So I think it would be captured as a natural part of what we're...
But it's not just that, though, is it? It's also about thinking through that while that transition's happening, that we might need to double run.
Yeah.
And how are we going to do that so we don't put it's quite complicated.
Yeah, Paul.
So I know I hear it a lot that actually, the vast majority of people, there's so many more people are seen in one sector than another. Some sectors are inherently more expensive than others and always will be. Secondary care, because of some of the things it has to do, will always be more expensive to deliver than some other services. For me, what would be really interesting is looking at where would be the right place for individuals to be managed compared to where they are managed now, and see what that would look like in a COG. So some of that would be shift of resource. It would start to articulate what the shift of resources we should be doing to manage people in the right place. And the second thing, we'd then start to see the fallout. Okay, so what are the potential efficiencies that come from doing that right? And I wonder whether that's a slightly more sophisticated way of approaching this rather than just in crude numbers, because then that starts to say not what are the crude numbers at the moment, but what's the ideal way of managing each patient when they present with a health need, and what's the most efficient and most appropriate place to do that, and then map that across, therefore, where do our resources need to go.
Okay. I think that needs thinking through, actually. So food for thought on that.
Will we just leave it at that, Jen?
Well, Forbes, I had you next. So.
Yeah. Okay. Thanks. I welcome the conversation about the COGS and all the all the points that have been made. That I fully support. In short, our financial plan has to support our other plans, hasn't it? So you can't have a plan that says we'll deliver more care in the community, we'll deliver more prevention, meanwhile our financial plan supports the sort of continued growth. And that's really what we've seen within the NHS over the past 20 years, and the evidence is there. So, the mature system will take action to address that. And there'll have to be a period of transition and double running, but actually it's got to put the markers in the sand and have a delivery plan against that. So, and it should be about right place, shouldn't it, for the patient. I think first and foremost, which is really good, I think that we've got to financial balance at the year end. And I hope that doesn't penalise us going forward, from previous conversations about the approach of NHS England to those that are in financial balance. My second point is, I reflect back to the previous presentation you gave of one of the development sessions, Rob, and I fully support. And it's in the review, isn't it? This dependence on non-recurrent funding. Great, we've got to year end, we're saved, we're still alive, but actually, we might fall off the cliff tomorrow. And can we create a mechanism where we're less dependent on that? Because it's no way to work, is it? It's just no way to work, really. And my third point really was just about the agency spend. We've struggled to manage that in Dorset. I know we've got a plan through the provider collaborative looking at that, but at the moment it's moving in the wrong direction. And in order to deliver much of your stuff, we need to get some control over that agency spend.
Okay. Just on this non-recurrent funding issue, and that's something that you've said yourself, Rob. The sense is that some of the money that the NHS has at the end of the year to divvy out to people and to support things comes from their underspend and things like dental. And that's now being transferred to us, but it's being transferred to us and ring-fenced as to what we spend it on. So we need to do something about not depending on non-recurrent, because it looks as if we'll have less of it going forward, as well as the fact that we have to reduce our own spend.
Okay, so sorry.
So very, very cognizant of that fact about the non-recurrent recurrent. And I know you could probably go back every year and hear the same thing said by people every time. Hopefully we mean it when we say it this time. So we've started up the it's early days, but that whole bit about how do we get into and try and, sorry, Patricia, time's a continuum. Don't forget one of my sayings here.
As long as you don't say this is the first day of the rest of my life.
No, that was last year. No, and time is a continuum. And we, in the NHS, because we wait for the funding, we kind of stop, spend a bit of time while we work things through, and then start again and stop and start. And it's always the 1st of April is the stop and the start bit, sort of some months either side. And yet you've got all your services and all your staff there and everything, and it comes back to that continual quality improvement thing. And it's easy words, but we find it really hard in the NHS. And we should have programs that are continually running, continually go after this stuff, which does then turn into more the recurrent way of doing it, as opposed to non-recurrent. So that's what we're trying to do. The medium-term financial plan will show how we will do that. And as Patricia said, we'll have a transition period where we will have to balance it off as much as we can whilst we get to that point. It's not going to just happen overnight. But that's what we're setting out to do. We just need to explain that.
And yeah, the obvious is the risk in the recurrent position going forward is high, and it's probably one of the biggest risks most of us are carrying. I just wonder whether in Dorset we need to consider as part of our sort of OD or development of staff. It was something for me culturally about actually how we embed some messages about value and best value and using the Dorset pound in the best way with all our staff that actually could be quite beneficial. So I just think it's something we should consider.
That was the second page of the outcome of the slides. We've got the first bit about the stock take of what we're doing, and the second page of the kick-off meeting was it included something around having a value culture embedded across so that people have it top of mind. I don't know how to do it, but it was something that we all agreed, COOs, FDs and other chiefs, that's actually what we need to do as well.
Okay, Neil, I'm going to take you as the last one, and then we're going to move on.
Thank you. Just to come in on that final point about the Siobhan made and Rob pick up on value, as some of you may know, we're starting a small piece of work with some support from Muir Gray and his team, all about, and we sort of as very much as a small piece of work first, get people who are passionate about this, see if it works, and then potentially roll it out and sort of under a name of the Dorset VIP, the Value Improvement Programme. But it's just to the point that Siobhan and Rob made about helping build a culture where everyone thinks about value and it engages everyone across the system with that drive, that how value delivers the best for everyone and the best for the Dorset pound. But it's very early days. We're just sort of scoping out what that might be as a sort of test bed first with people who are passionate, and then when it's sort of got a bit more information, we'll bring it back to the board. But it's great that there's sort of widespread support for the concept of value. So thank you.
Okay, so lots of discussion, Rob, around your cog page, which I'm sure wasn't intended, but I think the point is that it's showing us a skewed perception for where we think we need to be if we're focused on prevention and health inequalities, isn't it? And it's much like the slide that I know Patricia uses now that I think you presented when we did the financing around how housing, the investment in housing hasn't grown and everything else has, but we know that it accounts for 50% of the determinants for in relation to health. So that's what it's about. I think what you're hearing is people don't want it to become complicated, but I think the point that Matthew made around demand and how we manage that supply and demand by looking at this is probably an important one. So we'll leave you to go away and play with Paul on cogs and whether or not they can spin or not, and then see what you come back with. So I'm going to move us on to Patricia to take us through the review.
Thank you, Jenny. So I'm going to, again, assume the report's been read. It does go into the detail of the review because you can access the full report online. The review was originally Patricia was asked by Jeremy Hunt to conduct the review and then received a formal invitation from the Secretary of State for Health and Social Care. So we started the work in December. I was a member of the review panel, and then we agreed very quickly that we needed to get into 5 different work streams that were the principal focus of where the review needed to land. We were asked to do 2 things. We were asked to identify some short-term actions that would move systems into a different place in the context of the legislation around some of the operational challenges. But actually, the more important piece of work was for us to provide some recommendations about the long-term priorities of systems and how they might operate in the wider NHS over the next 10 to 15 years. We established 5 work programmes with members from right across health, local government, third sector, private sector, every possible avenue you could think of. I was asked to lead with Joe Rafferty, who is the Chief Executive at Liverpool Community Trust, the work programme on prevention, population health, and we broadened the scope of that to include health equity because it felt a bit strange that we weren't going to be talking about that in the context of where health outcomes were and the focus in the NHS long-term plan on reducing health inequalities. So what the report gives you is the principles that the report is bedded in at the beginning and some of the high-level recommendations that were agreed. I think some of the the key principle that came out of the work is that if we look at the new NHS operating framework and we look at what the statute requires of ICSs, and particularly our accountability to our communities, then what we were pushing for was a small number of national priorities, and not, like I said the other day, not 3 or 4 that have 35 indicators sat under each one, because that's not 3 or 4, but 3 or 4 national indicators that are grounded in things that are important to the public, like elective weights, access to GPs, but that actually the rest of the agenda should be set locally by engaging with local communities about what's important to them. And that also the ICSs should be given the freedom and space to deliver on that really important work within an agreed framework of accountability into NHS England, the Local Government Association as required. So we also talked a lot about the need to make an intentional step around moving NHS funding slowly but surely on a scaled basis into prevention and away from response. We're currently waiting for the response from the Secretary of State, partly because he's also working with the Treasury to review the NHS long-term workforce plan. That is we're currently in negotiation around funding for that, but we are expecting a formal response in the next couple of weeks. We've no reason at this moment to believe that all the recommendations won't be accepted, given that ministers asked for the review to start off with, and the Department of Health were very closely involved, in fact provided all the Secretariat for us. The NHS operating framework, the new one that has just been published, has been developed with the assumption that the Hewitt review recommendations will be accepted. And then it's about how we make them a reality. I think we are quite far ahead of the game in the Southwest. We already have a very permissive environment with our regional teams, and the plan is to broaden the scope of our ability to act and the ability to act with freedom, and only move into a regulatory conversation. And I mean as an improvement conversation, not as a regulatory intervention when performance is not being delivered. So I think we're in a good place to move into what the Hewitt review requires. And once we know that if government has accepted all the recommendations, then we'll start to look at what that means for us in terms of how we move forward.
Okay, so any questions or comments?
Just a comment, and I think it's really helpful to bring this. I think this paper's been the sentiments in this paper, and I know you gave us some early sort of messages about it, Patricia. The sentiments are correct, really, but are very supported, and I sincerely hope it does get the support centrally, because it's, there's the fuller stock taken. There's this paper that people are actually paying attention to and resonate, makes sense to those to whom we will look to deliver this, and therefore I hope it gets the support to get the traction.
Thank you. I would strongly support what it's saying about 1% of the budget being used on prevention, because it's completely in line with the kind of things that we're trying to do. And when I read the Hewitt report, I thought it was very good in a lot of areas. I think we need to, they need to, not us, and when we apply it. When this has happened in the past in times in public services, and they say you have to set this much against something that's a new priority, what sometimes happens is that people just start finding things they've already got that they can pretend are this, and they lose the intentions behind the directive, so that they can just comply with it rather than actually try and engage and do it. Now, we won't do that, because I know that we as a board and the executive here absolutely support this and would welcome it. So I hope that's true elsewhere.
So do I. And I think we talked, when we had the debate with colleagues at NHS England around the 1%, the position we were coming from, Joe and I, was not that some new programme of work had to start, it was about saying that the existing work that we're doing in terms of the long-term plan, that we need to reimagine those programmes of work through a lens of prevention and health and equality. So the example we talked about was that we already have a focus on perinatal mental health, but it focuses on quite a severe end of mental health. And if we broaden the scope of that to focus more on low level, then we know we'll be preventing mental health issues arising for children and young people going forward. So it's about reimagining what we're doing and using our resources differently. And I think there is a risk that if we don't stay in that space, that the ambition will be diluted. I think there's also something around, in fact, we were talking about that this morning, is when we're just doing, Bex and I have been doing some wordsmithing on the 5-year forward plan, want to simplify the language, but also to direct it at our community rather than writing it in third-party language, to say things like, this is what we know about your health and well-being. So what we need from you in partnership is for you to do this and we'll do that. And we've talked a lot nationally about the NHS's 75th birthday. And whilst there's a great opportunity to celebrate all the achievements, there's also, we think, as chief execs, a sort of moment where we can actually create a narrative to the public that also says, this is all great, but actually now we're going in a different direction and this is why. Because we want to improve the overall health of the population and bring the cost of health down. And I think, just to Siobhan's point around how do we create this different narrative to our staff around value, I think there's some work for us to do actually over the next couple of weeks, that when we launch that paper into the public, maybe we do it in concert with the 75th anniversary and we use that as a platform to say, this is now what you can expect going forward, and this is why, and this is what we need you to do to support us to move into a different direction.
That's a really good idea. Let's hope the timing of that works. And we know that you'll keep us posted anyway on where things are at with that. So thank you very much for that. Dean, I'm going to go to you for the plan for recovering urgent and emergency care, which is obviously formed part of our discussion today.
Indeed, and I think we'll probably make up a little bit of time with this one as well, because we've discussed it at the Finance and Performance Committee. We've discussed it kind of really through the performance report as well. But I just wanted to bring, because it is of such significance to us as a system, kind of how we recover the urgent and emergency care system, because that allows really many other things to be delivered as well. So it's building on I think the really successful approach that we've had during the winter of how we have delivered and how we've organised ourselves around kind of 3 tiers of work. So kind of the today, kind of the resilience that we've got for today and how we manage the in-day position, kind of the weekly position where we look at our plans that we've got and adjust our plans kind of either slightly or kind of more significantly as the system requires, and then our longer term commissioning and strategic kind of direction for how we want to take our integrated urgent care. There is a national recovery plan for urgent and emergency care, which is summarised in the paper, and we've aligned our plan for next year to be part of that and brought out from that the particular elements of the plan that we're going to focus on for next year. I think that's probably all I'll say. We will monitor it through the performance report that we've got and kind of any ad hoc reports too on how we are going to deliver this plan next year.
Thank you very much. So any questions or comments? It's here for assurance, so and as Dean's already said, it's already been through committee. No? Okay. Looks like full approval there in terms of assurance, Dean. So, and of course, we'll see the implementation over time around the areas that's been set out. So let's move on then, Debbie, to the Infection Prevention and Control Annual Report. Again, it's not here for approval, is it? But it is here for assurance. So.
Yeah, it's what you've got is the Infection Prevention and Control Annual Report. So hopefully everyone had a chance to read through it. I'm not an infection prevention control expert, so we brought our IPC lead to our quality and safety committee, and we had a bit more of a detailed discussion around this annual report and what it means for us. I think reassuringly, an infection prevention control network and monthly meeting was established through the pandemic, and actually has became a really effective partnership meeting across our system, and that's continued, and they continue to meet on a monthly basis, and they've used the relationships they built over the pandemic to carry on doing that really good work across the partnership and across the system, so that's really helpful. I think sort of 2.3 just talks about the development and introduction of a new quality assurance tool that's incorporated in the CQC key lines of inquiry for primary care, so that to help primary care with regards to their compliance for infection control. So just wanted to point your attention to that. We've already talked about the C. difficile issue. I think there's in section 3 there's a good sort of outline of the proactive work we're doing in the hydration arena, sort of for our population of men over 70 in the community, and we've already done quite a lot of work in our care homes in this area. So moving us again to that sort of preventative, trying to get people preventing infections in the first place, and UTIs and that kind of thing. And otherwise, yeah, I'd happy to take any questions, and if I can't answer them, I will ask Tina. But yeah.
I presume Tina's not on, so when you say you'll ask her, you'll come back to.
I'll come back.
Yeah,
she's my IPC nurse, but yeah, I think it's hopefully self-explanatory as a report.
Okay, so any questions or comments? This is obviously an annual requirement, isn't it? So we will
annual requirement, yeah. And as I say, it's been for quality and safety committee, which is where it needs to go. So.
Yeah. Were there any issues that came out from quality and safety committee that
no, the only issue was the C. diff issue that we escalated in our escalation report, and the fact that we're doing that piece of work to see whether we can get into the bottom of that. But otherwise, no, it was felt that all of the work streams that we had going were
the right ones,
right and appropriate. Thank you.
Thank you, Sam.
I think if Manish were here, he'd tell you about the assurance that quality took from, and I'm sorry, I've forgotten the lead's name.
Tina.
Who was all over the detail, answered every question, really knew her stuff, and the quality and safety committee took a lot from that. Channeling Manish a little bit, but I'm pretty sure he'd say that if you were here.
Hence why I'm trying not to, because I'm not in that space. And she really is. She's really knowledgeable, which is great. So.
I mean, the IPC leads really came into their own during COVID, didn't they? And it has, I think, sharpened the mind of organisations to just kind of continue doing some of these things. So. Okay, let's move on then. Clearly, the paper speaks for itself. So we're not going to put you under any heat to answer questions that might be difficult. So let's move on then to the Dawn, I think we're coming to you, aren't we, for the ICS brand and identity.
Thank you, Jenny. And right on cue, we have a person who I will give a moment to take a seat, and Kirsty will take us through where we've got to so far and the ask of the board today. Kirsty.
Hi, thanks for having me along. So we've been on quite a journey around the brand and an identity for the integrated care system and ICP, and actually had some great stakeholder engagement with lots of people. So the paper's been to a number of places. We've been speaking with our stakeholders, with informed stakeholders, public and wider groups. So hopefully many of you would have seen the concepts before today and before coming. So today was to get some sort of final comment and to note then what will be presented to the ICP at their next meeting for us to then start the sort of transformation programme to get them going and move over to the new brand.
And Kirsty, are you wanting the board to kind of articulate its preferences around the two that you've got. What do you want from us today?
Yeah, any sort of final comments really that anyone wanted to put forward around the name. So we've got two names sort of on the table that have come out from the main feedback. I think quite strongly many of the stakeholders and public really identified with Our Dorset, questioning why would we change it. They all kind of know it, and it felt kind of community and that they were involved, and it felt that they were part of that. So it's just to check in that was the sort of consensus view from everybody here. And around the brand being positioned as a true partnership brand that can sit alongside everybody else's branding. So I think that's the sort of key difference with this one, is that it can be used with any of the partners, a range of colours that we can adapt to sit with your organisation branding, so everyone can feel proud to be part of this partnership.
Do we need to recognise that we can't use One Dorset anywhere because we use that in some version of branding?
Great, okay. Yeah, that feedback can come back to us, but that's really good to know.
You look a bit confused.
I didn't hear what Patricia said.
Okay. So apparently one of the pieces of feedback Dawn got was some of the documentation that BCP uses says One Dorset on it, so we can't use that, apparently.
Okay. What I would say before I come to questions, and I know I'll go to Dan first and then Spencer, but the Our Dorset does convey ownership, doesn't it? So you know, we're all in it if we're talking about Our Dorset. So that would be my preference. But anyway, Dan.
Thanks. I really liked it also, thank you. And probably slight preference for Our Dorset, but they both really work and the branding works. Mine was more of a clarification question, because the paper talks about ICS or B brand and the deck talks about ICP. So I just wanted to check, what are we actually branding? And if we had input from the ICP, if it is the ICP rather than the IC.
It's the integrated care system. It's what do we call that and how do we brand that? And once we have had our conversation, then it will go to the ICP then for them to take a view. But it's our joint brand.
So it'll work across both?
Yeah.
Okay. Okay. Thank you.
Right, so Spencer, then Karen, and then Matthew.
The thing I find about branding is that if it says Our Dorset and it says working together, I just arrived from Mars. Working together on what? Why doesn't it say Our Dorset Health and Care working together? Because it says what it is on the tin, and I think it's a missed opportunity. You're going to brand it with a definite, with the strapline underneath that clearly defines what you're working together on. I don't see it. It needs to stand on its own. It doesn't have to have a book telling you what Our Dorset is. It just needs to be really clear, crystal clear.
We need to be really grateful that it's not the half-eaten apple that we had last.
Right.
Did you want to come back on that? Because it does make sense.
Yeah, no, that I've got no views one way or the other. That's why I wanted to come here today. We just used the phrasing that we put in the ICP strategy. As a kind of a temporary strapline, but happy to take views and to come back with something more appropriate.
And has that issue come up before through any of the consultation?
Yeah, it has. Okay. So no, that's fine. I think what did come back though was maybe to recognise the wider partners. Does Health and Care do that with everybody that sits around the ICP?
We've got two people that wanted to come on that point, so let me bring them in before I go to the others. Then. So
that's exactly what I was going to say. There's our ICP and our ICS is made up of more than just health. Just whether it recognises all of the other partners.
Is that what you want to say?
Yeah, I absolutely take Spencer's point around, you know, does it convey what we want to do? But I think Health and Care is too narrow, because it just, you know, if you're not in health, you're not involved, and we're not. We're what 80% of what we need to do in our communities is not health.
Yeah.
So I would try and avoid that. But I Spencer's point around there was perhaps something more we could do, but we can build the association. You know, as people get used to it when it appears next to the work we do in the document, maybe that comes, but it doesn't leap off the page.
Okay. Right. So then I've got Karen.
Hello. Spookily, I was going to say just that actually about the strapline. I would be remiss if I didn't, wouldn't I? And I agree, just backing up what David has said. And I think a strapline is important. I think it's really important to be really clear what it is. And but I really like our Dorset. I think that's, you know, I really would support that. But I think a strapline, yeah, sorry, Kirsty, that's a task for you. Nice and natty to put, but I know you can't get everybody in it, but I think it might feel a bit exclusive. People might not quite get what it is if it just says health and care.
Okay, Matthew.
Thanks very much. So hi, Kirsty, I'm Matthew Bryant, Chief Executive Dorset County and Dorset Healthcare. So I'm so new to this, I contribute with great hesitancy.
Have you seen the Apple?
I thought it was a really good paper. So with my new eyes, as it were, I felt much more comfortable with our Dorset as an outward-facing message, and I think it really conveys that sense of ownership, inclusivity, and also responsibility that comes with it being our Dorset. I think this is like a very obvious point, but I think for us as the ICB team and our senior teams, there's definitely something about one Dorset in the way that we work as a behaviour and the way that we own each other's problems in different sectors. But that's a slightly different thing to this outward-facing branding.
Okay, Patricia.
So all I was going to say is, I think it will find it impossible to find a phrase that includes, well, to identify all of the partners in it. We could do health and care, voluntary sector, community, we'll just lose. But there was something that came to my mind last night was whether we want to say something like working together to support thriving communities, because that is effectively what we're doing.
What
that's
done is explain the outcome. It doesn't explain those involved in creating the outcome. That can be really provocative.
Well, we could say everyone working together to support thriving.
I think it's something to take away, but I do think having the right strapline is absolutely key to getting the branding right.
Yeah. It needs to say the same thing to everyone.
Yeah.
At the risk of trying to walk the wheel on contentious waters, I knew that this item of the agenda was going to be live. It really is. And I'm glad it is, because it shows how much everybody's committed to this. So in some of the conversations that Kirsty and I have had about the preference towards our Dorset and the strapline, there's something about our Dorset, meaning everybody that looks at that who either is part of our community in the broadest sense, either staff or people, it's us, it's our Dorset. And the working better together is we are all involved in working better together, and it links to this part, the point that Patricia made earlier about using the 75th anniversary of the NHS to reposition the contract between citizens and in terms of looking at responsibilities for healthcare and well-being, and working better together with our Dorset speaks to some of that in theory.
I
think we have to manage our expectations. There is a difference between brand and logo and strapline. And I think we have to manage the expectations of what a logo and a strapline can achieve. For me, this is great. I think the credibility behind that will be delivered in what we say and what we do and what we deliver. So, you know, I think let's not try and make something that can't possibly deliver everything. This is a logo and it's a strapline. The brand underneath it is below the waterline. What we deliver will have a massive impact on how credible this is, probably much more in the end than the colours and what it says and what the strapline is. So I think it can only do so much. And for me, our Dorset, in this sense, does it really nicely.
Matt?
Just to add contention to that, if this is about our Dorset, and that's about everybody in the partnership who works in our Dorset, I wouldn't align it to the 75th anniversary of the NHS because it becomes NHS. That's true.
And the reference to the 75th anniversary was simply the contract, right. not lining our brand to that.
Okay, well, we're not going to get into we're not going to get into this because we're obviously not going to solve that today. But I think if people have got ideas around the strapline, please get those to Kirsty, and then you will just weigh up in you know the sea of the ones that you've had already, and make some decisions about it. It feels as if most people, though, are saying that our Dorset is the one that we're behind. Yeah. Is anybody that feels differently?
I wasn't for it, but apparently I have to because somebody else is really going to. That's fine. I mean, if we're sure about it, that's all right. We can go with that. So, amend the comments you've received from us already.
The problem is we haven't got BCP here, have we? To say whether or not that's the case. So, but anyway, so our Dorset seems to be the preference. And then you've set out what you're going to be doing next, haven't you, in the papers? So we'll leave you to do that. As I said, if anybody's got some really what they think are thoughts around something that hasn't been said already around the strapline, I'm sure Kirsty would be happy to hear that.
Absolutely.
But I think you've got to steer from the meeting, Kirsty. It's our Dorset, and then the rest of it will lead to your difficult head to sort.
Thank you. Thanks very much.
Thank you so much. Okay, so then that brings us to questions from the public, which we haven't had any in advance, so we won't take any questions from the public. I have also, sorry, something wrong, Dan.
Is there a paper on people plan, or have I missed? Is that after?
No, it's consent. So how the consent items work is that they do get distributed, and hopefully everybody's read them, but we only have them here for discussion if people indicate beforehand that that's what they wanted to do, and I haven't had any indication. But are you raising that because you did want to discuss something from the people plan?
Sure, I'm under pressure to say no.
It actually does say on the agenda.
I missed that on the agenda.
Yeah.
I'm happy to pick it up. I'm happy to pick it up with Dawn offline if that's the case. It's a really small thing, so.
I mean, we have got time, so
No,
I mean, Dawn would not have been expecting the discussion, but if you're okay, we're happy to take some comments rather than questions.
I feel like I'm breaking the rules if I break stuff that. So I'll be really brief. As I said, it's great. I really like it. I just wondered what had come from the last discussion. We talked about the measurement of it being quite metric heavy and quite rightly ambitious about the headline metrics. And we talked a little bit about softer anecdotes and insights from how people were feeling. And I just wondered how that had been built into the plan. Because I couldn't quite see some of that. So that was my question. Apologies for breaking the rules.
So I'm just going to, because that's a question rather than a comment, so I'm just going to check if anybody else has got anything before Dawn comes in. So that's okay. Dawn, do you want to? Are you happy to come back on that?
Yeah, absolutely, and thanks, Dan. Part of the reason for this coming for consent was following on from the board development session that we had on the people plan at the last board. So in terms of the metrics and the measures, I think, Dan, you raised a really useful point in that the measures of success for this people plan will not be solely based on quantitative
hard measures. The qualitative data that we receive from how it feels to be part of the whole system workforce across Dorset is going to be integral to our success measures. The measures that you see in the strategic document are really high level stuff. Underneath all of those sits a basket of both quantitative and qualitative measures. So as we get into the implementation plan, the delivery plan, and then the more specific definitions of what we're aiming to achieve in each area, then the difference in the hard and the soft metrics to measure that become clearer, and so PCC will see that through the work plan. So the short answer is absolutely yeah. It's in there, and it'll become clearer as we drill down into it.
Brilliant. Thank you.
Thank you. And also thank you for indicating that you have read it, because it is important that people read these, otherwise we don't know whether or not you want to have a discussion on them or not.
How should I read it? Maybe I was just bluffing.
The bluff, so that brings us to any other business, and I'm going to go around the table, starting with Matt, because he's indicated he's got
It's actually a date for next meeting. It's just, as you're aware, obviously BCP aren't with us today. They've got their elections running today.
Yeah.
The 6th of July, BCP will actually be hosting a Local Government Association conference, a national conference for local government. So again, Dorset Council and BCP won't be able to attend. I'll be happy going forwards, my office and Graham's office, I'm sure, to work with Liz around the longer term dates around those things. I'd love to make the LGA conference sound more exciting than it is, but the reality is we need to be there. It's the point where we'll get an opportunity to, listen to and hear from and possibly speak to our Secretary of State. And as it is local, I have no doubt that Graham won't be able to sort of find his way apart. We were in Harrogate last year, so we definitely wouldn't have made the meeting. So we've had a couple of these occasions where we've just, I know it's really difficult diary management, but I'd like to offer that sort of help going forward, that annual cycle to try and avoid some of those, those clashes.
That will be really helpful, because I know the Secretariat to go out to all partners and local government to set the dates. And to be honest, I hadn't even clocked that this one was going to fall on the day of the election. And I think Graham raised it with us a day or so ago. So it was just too late for us to change it. We have got next year's elections date noted.
Yes.
So the same thing won't happen.
We have elections this side of Dorset next year.
But that will be really helpful, because something's obviously gone awry where the other secretariats have not picked up some of the key things going on. So if we can just link in with the right people to make sure that we get those dates sorted, that would be really helpful.
I'll be happy to help on that.
So thank you for that. Yeah, we'll have to think about 6th of July then, won't we? So we'll come back to you on that. Anything else from you, Matt? No. So let's go around the table. Matthew? Spencer? No. Baby? On the screen? Oh, no. Anybody at the back there? No. Okay. So that brings the meeting to a close. The next date is published as the 6th of July. If we can move it, we will, but I suspect it will be quite difficult to do that at this late stage. So, yeah, I'll come to that. So, but we'll come back to you on that one. And then just the last thing was the key messages that we picked up during the meeting. So I'll go first, and then unless you just want to go straight in, Liz, I picked some up that I think are key messages. So from the beginning, we had the video, didn't we? And I think one of the key things that came out of that for me was about people first, not just in terms of our communities and who we're working with, but also the workforce. And I think that did link up to some of the other discussions that we had later on, including the Hewitt report, actually. But I think some of the things that's come out in that, if we pick those up, it will actually deliver some of those key messages that came through that. And the second thing that I've written down was around prevention and health inequalities. This screen's going off.
Oh, possibly.
Probably tells us that we've reached the end of the meeting, but we'll try and keep you with us. So prevention and health equalities, and how we link how the performance data develops in relation to those things, and how we ensure that they link to the committees as well in terms of the oversight of that. A lot of discussion around the COGS, but I guess the key thing with that was around how is there a way to depict the trajectory of where we want to get to in relation to prevention and health inequalities, which is the previous one, and the value that's been added to that. So those were the ones I put down. Have you got anything else?
No, we talk quite a lot about thanks for teams across the partners, especially on the year-end position in terms of finance and performance, and especially on the no criteria side. And also how much that was affecting about the partnership solidification and the maturing of the partnership. I think everyone to bring that out. Yes, and also look really around the branding about support for our also for the
Great. Anything else that anybody else thinks? Okay, you've earned your lunch. We've got until 1:40. If we could come back at 1:35, then we can resume on time. Thank you very much. That concludes the part 1 meeting in public. And when we resume at 1:40, it will be the closed session. Thank you.
Time that one out, yeah. Camera watching from afar.